like this could go. Right. The problem is the storage room. Do you see how out of control it is? I hope they can get to things in there to like. It's you just have a lot of stuff. So you, is that the plug that goes, where's ours? Ours is this, Where's our, this is your plug, right? The one.
The cable, yeah.
Yeah, cable, that's what I mean, not
You need.
So we're gonna need.
You want to just leave mine there? We can unplug it.
Well, no, right. No, that's fine. I just don't know where the thing is for her. Right. Where's the one that was originally in there? This is. Oh, maybe that's it. There you go.
Yeah.
Okay, perfect. Thank you. Thank you for all your help, James. Sorry. We don't need that. We're just gonna share this. Yeah. We need Havdalah. I'll take care of it. The Havdalah, do you know that candle? It's okay. I'll take care of it.
So it's going to get flipped. Yeah, I'm afraid I'm going to go. Yeah, because it could bang against the tree.
Test, 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 test. 1, 2, 1, 2. Test 1, 2. Testing 1, 2. Hello? Hello?
Check, check. Anyone want to hear a rabbi joke? Just kidding. Okay. Or a moil joke. No, we're not going to do that. She's a moil in her spare time. So, hi everybody. If you are watching at home, I just want to let you know that you can email questions if you have them to Wendy Barr, or actually to me, Rabbi Gerson at grs.org, and we can include your questions if you're watching this presentation at home. So I am thrilled to welcome my parents, Rabbi Gary Gerson, Dr. Carol Gerson, to lead our symposium this afternoon. Just a brief word about them both. This is going to be fun. Rabbi Gerson the first is the Rabbi Emeritus of Oak Park Temple in Oak Park, Illinois, where you were 30 years. Were you there for 30 years? He was the senior rabbi there for 30 years. He retired a bit ago, but he still teaches at the synagogue. He teaches classes in Jewish mysticism and other things, Jewish spirituality. He also teaches my parents spend the cold months at Touro Synagogue in New Orleans, so he teaches down there at Touro Synagogue in New Orleans as well. This is my mother, who retired, we call it retirement in our family, and proceeded to get a PhD in bioethics. Become a doctor of bioethics, become a moil, take up quilting, and does yoga. So they are both, I have the utmost respect for both of them. They might, most of the time, and it is, but it is such a treat and a privilege and a pleasure to bring them here. They've been doing, just one additional word, throughout the pandemic, they offered their services as teaching bioethics classes together at synagogues all over the country, and they did it and all over the world. They did this for free as just something like they wanted to give back to the Jewish community. And how many synagogues do you guys think that you were at? So they did something during, between 50 and 80 synagogues, and so we're very lucky to have them here this afternoon. And welcome to Greenwich.
It's good to be back.
Working. Good. Okay. So what I'm going to do to begin this is just give us a framework of how we're going to talk about these ethical questions. There are many different ways of approaching bioethics. This is one of them. It's called the principlist approach, and it's based on, it's based on 4 principles. And the principles are, theoretically they're all equal, but autonomy, the first principle, tends to be the one that gets the most attention. So what does autonomy mean? Autonomy means if you're the doctor, Sandy, and you say to me, you're diabetic, you need insulin, I have the right to say no. I have the right to say, I'm not going to take that medication that you've recommended for me, for whatever reason. That is assuming that I have decisional capacity, that I'm able to make decisions for myself. That's not competence. Competence is a legal term. So in medicine, we talk about decisional capacity. What I do not have the right to do, I don't have the positive right to say to you, you say to me, you're not diabetic, and I say, I don't care, give me insulin anyway. I don't have that right. I have the negative right to say no. I don't have the positive right to demand something that the physician thinks is inappropriate. So that's autonomy. I can decide for myself. The second principle is beneficence. If you're going to do something that's good for your patient. In other words, if your patient has diabetes, give him insulin, so that's good for him. The next principle is non-maleficence, not malfeasance. They look the same, but they're spelled differently. Non-maleficence, which means don't do something that's bad for the patient. Don't amputate the wrong leg. Don't give them the wrong medicine. And the fourth principle is justice, which is that the concept that people in the same condition should have access to the same treatment. that there shouldn't be discrimination, and there should be justice in the distribution of resources. So that's the framework in which we're going to talk about this.
I would add that when we shift to specific Jewish views, which are casuistic, that is to say, it's case by case, and from that you extract a set of principles, we are going to find that there's some variation in the response to some of the more general bioethical principles that are discussed in Carol's secular context.
So let's start with the big one that we used in the introduction to this that was sent out, which is you have 2 patients and 1 ICU bed. One person is vaccinated, has worn a mask, has done social distancing. The other patient is not vaccinated, has denied that COVID exists, has refused to wear a mask, has gone out and partied and gone to bars, and now it has COVID, clearly has COVID, denies that it's COVID because they don't think COVID exists. You have 1 ICU bed. Both patients are medically in about the same condition and both need the bed. Does the fact that one person did everything they could to protect themselves and the other one did not, should that have an impact on your decision of who you give that bed to? You're the doctor.
Should it?
Is it going to make a difference in who you decide gets the bed?
I can say not what I perhaps want, but no.
So tell us a little more about that. What do you want?
I think if the best is the person who tried to prevent should get the bed. But there are probably, if one is 92 and one is 45, that would be a mitigating factor as well.
Okay, so age. What you've just said is age can be a factor in determining who gets a scarce resource.
But Jewish ethics respond, since every life is of equal value regardless of age, that is not necessarily a criterion. In fact, by and large, it is not a criterion in Judaism. Judaism then poses something else, and it is that you are responsible for your own well-being. If you neglect your own well-being and it has an effect on the wider community, then you take a step down in what is appropriate seeking out of care from the community. In other words, there's a two-way street. Ours as a Jewish community is a communitarian ethic, i.e., we are not only who we are as single souls, we are single souls in matrix of a community. The community can lay a claim on us, and in this case, not so much if you haven't taken care of yourself.
If you could hold the microphones out to anybody making comments they can't hear on the stream.
Okay, good.
So there's no triaging.
Hang on, I'm going to do the Phil, remember his name? Phil? Phil Donahue. Right, I'm dating myself.
Would there be triaging?
Okay. What's triage? Who knows a definition of triage?
It's determining whether what should happen to a patient, what should be the next step is triage, right? Before, I'm just thinking of it in, wartime and triage and making a decision about who can be helped and who can't.
Okay, triage is a military term. It comes from the military. And the medic in the field looks at all the injured people and says, I can't save that one. I'm just ignoring them. I'm not going to do anything. I might be able to help this person, so I'm going to put my resources where they're going to do the most good. So triage is a military term. Where is triage happening in this pandemic? At what level of care is triage happening? What do you think?
in hospitals, I think.
Where in the hospital? Emergency room,
In the
okay.
emergency
Emergency room is one answer. Where else?
Well, I mean, I think that the need for the breathing machine, the respirators, the ventilators.
Ventilators,
and-
okay.
Which I think are in the
Who gets the
ICUs.
ventilator?
Right.
Okay, so we have ICU, we have ER.
How about vaccines?
Well, wait a minute, we're not there yet.
Well, but is triage not part of the staging?
We're at the sick, a patient and where the decision is being made, who's not getting treatment for active disease. Okay? So we have inside the ER, have you read about situations in which ambulances are backed up? It happened in California, it's happening in Alabama right now, ambulances, and Tennessee. Ambulances are backed up at the door of the hospital with heart attacks and stroke victims. And they're waiting, and once in California, they were waiting for 8 hours to be able to get the patient into the ER. So that's a form of unintended triage. People to the care they need. How about what happened with the doctors? Is this working? Okay. What about the people who, if you wanted a doctor visit, or if you needed a surgery, a cancer surgery that was not an emergency during COVID? Remember when all elective procedures were canceled? So people did not get the surgeries they need. That was also a form of triage, unintended triage because of the pandemic. Okay, so now we're back to people who have not done everything they can. The simple description of a Jewish approach is, and this was based on captives, on the redemption of captives.
That you bear responsibility, first of all, to care for your immediate family. You can't immediately say, I want my name, husband, brother, wife, aunt, to be ransomed with the wherewithal of the community providing that money if you have not first dipped into your own pocket. That's because in Judaism, one of the ethical standards is based on the notion of concentric circles. In fact, it's a principle in almost all areas of Jewish ethics, not just medical ethics. You begin with yourself. You have to take responsibility for yourself. Then you take responsibility for your immediate family, then your extended family, then your community, then the Jewish community, then your outlying community, and then the world. So that sets a stage for the question of you have to take care of your own first before you can turn to the community. But if you've exhausted your resources, then you are more than entitled to turn to the community to redeem a captive, likewise in medical situations as well.
All right, so from that Jewish perspective, is the person in the ER who has not done anything to prevent themselves from getting COVID entitled to the same attention that the people who have protected themselves are? Who thinks they're not? I mean, that's a Jewish approach. Sandy?
Well, your hypothetical is there's only one. I mean, it's a binary choice. I either do this person or I do that person. I can sit and philosophize about why you should, sort of not take into account their lifestyles, but the reality is you got to take something into account, and the reality is that, at least for me, it would be relatively simple. Painful as though it might be, the choice would be, to me, obvious.
Now, people who
Carol,
argue
let me
against
add
that.
in. Let me add in. And what's interesting in Judaism, there is a position that is fairly well taken, that when it comes to care for somebody who is ill, and if it's an issue of triage, if they are not going to survive, and there is somebody who is not even at the door of the hospital, but is known to be coming in, and they have a better prognosis, that person can lay claim to what is in the hospital without even being there yet, if somebody else is further down in the ability to survive.
Now, as you know, with our medical system, we treat people as they come. So in the ICU, we're not going to say, you were a bad guy, you don't get it. However, the impact on people working in the hospital, taking care of patients, and feeling that this is a never-ending problem, we're exhausted, we're continuing to be exhausted, nurses are leaving, are quitting, because they are so angry at the people who have not protected themselves, and seeing people in their 20s, 30s, and 40s dying from COVID, it has taken a tremendous toll.
As some of you are aware from just a recent article in New York Times, actually nationally speaking, there's a hospital that stopped doing delivery of children, the babies, because the staff has said, we're gone. You're going to require vaccination of us. We're not going to do it.
Okay, now, we had a negative right to say no to treatment. We don't have the positive right to demand treatment that a physician thinks is inappropriate. So, and these cases are real. Somebody is in the ICU and their family comes in with a printout that looks really official, with a nice logo on it from a group saying, these doctors believe that ivermectin works. And I'm giving you the schedule of medication that I want you to give to my mother who's in the ICU with COVID.
To which you can respond, nay.
Oh dear. All right, so you're the doctor. Are you going to give him ivermectin? We have a number of doctors here. Everybody has the opportunity to be the doctor today.
Are you a doctor or a layperson doctor?
Okay, so.
A doctor has been educated to make the decision himself. He may consult with others, he may take input from others, but his decision is his responsibility, not others.
Okay, you're the doctor. You're going to give them the ivermectin.
I'm sorry?
Are you going to give it to them? You're going to give them that
If
the
I don't
ivermectin?
think it's the right thing to do, no.
Okay, so what happened? It went to court. It's gone to several courts. And there have been, court had said you got to give them the ivermectin. There were a couple of cases like that. So what do you do then? Do you give it to them? Michael, you're going to give it to them? Yeah, it's a court order. The court order says you have to.
Said, a lot of times we'll have to, especially in my field in pediatrics, where there's not clear-cut data on every decision we make, we incorporate the family as much as possible. And while, of course, this example is wild and crazy, in the end, you may be dealing with a wild and crazy family at the same time. And sometimes, if they're convinced that this is going to help and you can't prove them in the opposite direction, you can state all the reasons why you wouldn't do it to your relative, but in the end, if they're making the medical decisions because their relative is on a respirator, I'd probably give it.
hang on one sec.
I would take that step first. I'm a surgeon, and I would stand against the court order because I don't think that the courts can order me to. I would stand against the court order. I would look the other way with the court order. I would say no.
You'd refuse?
I would refuse a court order.
Yeah.
Thank you. Because I think of offering surgery as a parallel to offering medications, and there's no court or no family that's going to convince me to cut somebody who I think shouldn't be cut, and for whom I don't think that that would benefit, and for whom I would actually do harm. And so on a parallel, giving a medication that could actually cause harm to a patient that, from everything we seem to know, wouldn't cause any good or any benefit, I would tell the court to bug off.
So you're relying on the principle of non-maleficence. You're not going to do something to the patient that you think may hurt them.
Let me throw a wrinkle in. What if the ethics board of that hospital, concerning the question of ivermectin, says it should be given to anyone who requests it because there is no evidence that it does not work to the benefit of the patient?
I'm certainly not a doctor, but with so many people, nobody knowing exactly, how to cure or what's going to cure COVID, and certain drugs that have been used and seem to maybe have had some success in some areas, but hasn't killed anybody, that why wouldn't you try something? I mean, with my husband and son, they did the hydrochloroquine. And after that, everybody said, no, you can't take that. That's not good. That's not, that's a terrible thing. Well, you know what? They felt better after they took it. So,
But let's ask the physicians in response to the question, what happens if the ethics board says to you, you really have to give this if you're going to be working at this hospital?
And that, I think, is an interesting difference between giving a medication and operating on patients, which is, to take this step further into what I do. That's complicated when the ethics board is compelling you to give a medication. I mean, the hospital that I work at, we have.
This is good for theoretical discussion. It's important to know that an ethics committee does not have any teeth to require anything. What the ethics committee or the ethics consultant can do is tell you what are the ethically appropriate alternatives, but they cannot force you to do anything.
What happens if the board of the hospital and medical director, in response to the ethics committee, says, this is the standard of care of this hospital?
And as a physician, if you feel that something is not indicated, you can say, I'm not going to do that. And it would be real uncommon for the non-medical board of a hospital to say a patient had to have a specific treatment. That we're telling you, you must do this specific treatment even if it is against your medical judgment. Okay, so monoclonal antibodies have been around in this pandemic and became available sometime after the pandemic started and have been pretty effective in early COVID. In Louisiana, in New Orleans, the guideline was if you're sick enough to be in the hospital, you don't get it. You get it if you have early symptoms and you are not hospitalized. And for a while there, the minute if you had a positive test, you called the hotline and they had you in within a couple hours. They gave you the infusion and you walked away. There were other places in the country where nobody was using it. In Florida, Governor DeSantis, in an attempt to appear that he was not encouraging death by encouraging people to against mask mandates and, and everything else he has done with COVID, including not reporting their statistics. He wanted to look better, and so he has started touting monoclonal antibodies and saying we're going to give them to everybody. Everybody who gets COVID is going to get them. Now there is a concern about shortage of monoclonal antibody. The government has just bought 1.5 million doses to try to even out the distribution. So how is the government going to even out this distribution? Should they buy up all of the monoclonal antibody? And how are we going to decide who gets it? Should we decide by population? Should we decide by the number of COVID patients? Look at the map that shows up every day in the newspaper and go to the reddest states where they have the most cases and give it all to them. How are we going to divvy it up?
When there's been a shortage of any commodity, for instance, during a war, when there is a shortage of chocolate, food, whatever, then we do need, that's the government's place to come in and to make sure that the distribution is equitable. And in a way that they did with vaccines, and sort of initially when vaccines were in short supply, they were distributed so that they were distributed so they could get to the people who needed them, the frontline workers first, all over the country, instead of sending them to the wealthiest communities where people could have spent, thousands of dollars to pay for it. So yeah, I think the government should get involved and should limit it and should distribute it.
Okay. How are you going to distribute it? Where are you going to send it first?
I think that this is where the FDA or the CDC, that people who are knowledgeable about how they can most be used need to make those decisions.
Okay, so Helen, what we're talking about is the ethical decision of where we give this medication. Do we send it out by state population? Or do we send it all to the states with the least number of vaccinated people, without the mask mandates, who have the sickest people because of the way they have behaved?
But I don't think the monoclonal antibodies are for the sickest people. They're really used right when people are first infected.
So you could decrease the hospital admissions in those states if you give it to the people who just became positive and are not really sick yet, right?
But think about it insofar as we're talking in the Jewish context. What do you think? Knowing what Judaism has to say, that you have to take responsibility for yourself before you can lay claim on the community. And you haven't taken responsibility, either with masks or with vaccines.
I think you're setting a very dangerous precedent in that you have to look beyond COVID. I could very easily say, let's say somebody comes into a hospital with AIDS and their behavior caused the AIDS. Do we say, no, we're going to cut off the AIDS people because their behavior? If not AIDS, somebody who's obese, somebody who's diabetic. Once you start going down this path, you start taking a look at an entire society and a whole bunch and a whole range of diseases. And I think you're going down a real slippery slope once you say this behavior is one we're going to punish as opposed to any other.
That's a really good point, Ken, and one that I would have made if you hadn't.
Which takes to the nuance in Jewish ethics, which is if you have two patients with an equal claim to the care, well, in that case, then you have to start looking at the question of whose life is most at risk, and then it moves into a standard medical triage model.
Now, there is in some Jewish ethics the concept of social value, and whether or not the scarce resource should go to the person with the most social value, who could be.
According to Jewish ethics, in fact, it would be the most learned, Jewishly speaking, in the community. So, from a Jewish standpoint, there is one posek, there's one legal decisor in particular who has argued that, yes, because of this Talmudic principle, the people who are most valuable in the community, i.e. rabbis, and by extension then, doctors, or those who are first responders, should in fact be taken care of first. I have to tell you that although that position exists, it is basically thrown out by everybody else but this one particular decisor.
Yeah.
Let me broaden this in two respects. Supposing, and this comes up, I'm sure, all the time in medicine, somebody is sick and they decide that they need a tracheotomy, and the medical record shows that it says, do not resuscitate. No one will take responsibility for that, and the surgeon disagrees with that and is going to do the tracheotomy. That's one aspect. Another thing that is even broader is somebody comes into DSC Bethel Hospital, which I find is fascinating because it is actually a hospital in Boston, as I'm sure you know, and says, I want an abortion. And the Jewish point of view is that life begins when the head comes out of the womb, as I recall. Okay, and the Catholic view is that life begins at inception. So they have to make a decision as to whether they will do an abortion or not. So these are very real situations because I've seen them.
Yeah, they are. They are. And religion is a whole other aspect of these ethical decisions that comes in when it comes to end-of-life issues. And before we start talking about end-of-life, I first have to put in my plug for advanced directives. Hopefully everybody has an advanced directive. If you don't, you should. Yeah. So I just want to finish this plug that if you don't have an advance directive, you should. It takes a tremendous burden off the people who love you to make a decision. And those of you who are a little older will remember the names of Nancy Cruzan and Karen Quinlan and Terry Schiavo, and not one of those people was an old person. And they didn't get up the morning they had their disaster and say to themselves, I'm going to have something bad happen today, so I better fill out my advance directive before I leave the house. And young adult children and even older teenagers should have this discussion and should have an advance directive so that their families, their loved ones, your loved ones will know what your wishes are.
Perhaps we should shift to the question
There was
of...
a question we missed.
Okay, and then after that, I think we need to move to the area of vaccination. Who gets, who doesn't, what happens if they wear a mask, if they don't, the contemporary situations we're dealing with right now.
Yeah, now whose question did we miss? Huh?
Oh, well.
I think thinking back to my question, I was just interested in I think it's one thing to say that it's the Jewish ethical position to take responsibility for myself before I seek help from the community, and to use that for guidance to myself in my own life. But I'm curious, I think it's slightly different to take that Jewish ethical interpretation that I may wish to apply, be my own interpretation, and then use it to deny care to someone else who's come to the community for assistance. I think that involves a complicated judgment as to whether another person has taken responsibility for their self, which I think it's maybe quite complicated for someone else outside of that person's life experience to be deciding about. It seems more to me to be something to strive for in my own life, but given that it's very complicated to understand the situation that led the other person to be able to take whatever level of responsibility without knowing the information or their personal situation. I'm curious if there's anything in the Jewish texts generally about when you're using Jewish ethics. Is it meant to be guidance to yourself about how to, obviously you have to make choices that impact others, but is there anything to say on that point?
In the Jewish community, the idea is that the community, since it is being held responsible for the care for that individual, has a right to demand of that individual that they do what the community has instructed, whatever ethically speaking is required. So Jewishly speaking, if you are not wearing a mask even though the authorities in the community say you should, or you're not being vaccinated because the authorities in the community have said you should but you refuse to, Jewishly speaking, in abstraction, you have a right to put them in a second status position as opposed to the primary for the person who is doing what the community asks of them or demands of them. Carol, do you want to move into?
It's easier to use that concept if you're looking at the situation in which that opinion was written, which was redemption of captives. I mean, did the family pay to redeem the captive with everything they could afford? That's easier than determining somebody's behavior when it comes to contracting COVID. So you're right, that opinion may have worked in a simpler situation, but doesn't work so well now.
And the flip is, because that individual, by virtue of their not doing what the community has told them to do, is also then becoming what is in Jewish law called a rodef. They're becoming one who's pursuing your life. And as a result, they're endangering everyone else.
Okay, now we talked about moving on to the question of vaccines. So you know how we decided to divvy up vaccines. We gave them to the people who were most likely to die of COVID. However, if we wanted to stop the spread of COVID, then who was spreading COVID? If you looked at the numbers of people after the very beginning, when it was mostly the elderly, very shortly after that, every graph you looked at as to what were the age range of people getting COVID, it was between 20 and 30, 20 and 50. So younger people who were partying, who thought they were invulnerable, were most likely to be spreading it. Did we make a mistake in how we divvied up the vaccines? Should we have decided to give them to the people who are most likely to spread COVID to stop the spread? Did we make a mistake? What do you think?
Michael?
Yeah. If we knew that, if we knew who was spreading it, and we had the ethical decision, give it to the most likely to die, or give it to the people who are spreading it, which is the better decision? which is the more ethically appropriate decision?
Remember, in Judaism, you look at the individual life, and the situation is each life is of infinite value. Therefore, you cannot judge between lives. Michelle.
But we're communitarian, or we're a communitarian religion, and if it will protect the community more to prevent the spread, should our focus have been on that?
So that also would we'd also then assume that people would be willing to take it, and many of the people who were spreading it are the people that were unwilling to take the vaccine as well. So it was a double, I mean, I think as Michael was saying, I mean, we certainly didn't have that information, and it seems to me that the older people needed the protection, but, the people that were going out and spreading it, I'm not making any decision, just my own opinion, that people that were going out, not wearing masks and spreading it, they, again, were the people least likely to care and think they needed the vaccine. I know so many people in their 20s who said, I'm getting the J&J because it's one and it's done, and they know it's less effective, but they didn't care. So I just want to be vaccinated. So that's a very, the mentality of that age group.
And here's the situation. If you say, let us first vaccinate the young, and you then put all of your efforts to disseminate that vaccine, and you have a population that is recalcitrant or says, I don't care, I'm not as likely to get sick, then what time have you wasted, and what lives are you then potentially taking?
Okay. Knowing that, should we have targeted that community and mandated vaccine?
Now we're getting into the ugly question of what can the state demand of you?
Jewishly, if the state demands it, what do you do?
Dina de malkuta dina, the law of the land is the law. In matters that do not, involve a violation of Jewish law, you are obligated to observe what civil law demands.
We mandate certain tests, and I don't know if they're vaccines for newborns.
We do.
And I can't see how this is really different. I think we should be able to say, unless you can have a written excuse from a doctor that says this will harm you, it's for the good of the country and the good of everybody around you that you get it, and therefore we're going to require it.
So now we're mandating. So we're mandating vaccines, and we're saying to this younger crowd of people, you are required to get it. You're going to get a fine of $10,000 if you don't get your vaccine.
Sounds like Texas.
So, that's one approach. Now, when we distributed vaccines, we were distributing them to the people most likely to be seriously ill. But we know that our Black and brown communities got sicker than our Caucasian communities and our wealthier communities. Should they have been first, along with the elderly? Should we have said that people in these Black and brown communities were likely to get sicker, so they're next in line after the nursing homes?
I'm going to toss something in here. The Reform Jewish community has a number of different institutes that make such issues the topic of discussion. One of the most famous is the Solomon Freehoff Institute. Walter Jacobs, some of you may remember, died very recently, former president of the CCAR. The Solomon Freehoff Institute has said there are 3 criteria that should be brought into consideration, and when one of them is that of race, that does not apply. Race cannot be a consideration, but an underprivileged class, independent of race, may be.
So should we have included those communities in the very first people to get vaccinated? Did we make a mistake in not doing that?
Hang on a sec.
Thank you. I wanted to make two comments. One, in terms of vaccine mandates, this is nothing new. In my limited understanding of things, there were vaccine mandates. There was a smallpox outbreak in New York City, I think in the 1940s. It was mandated. The polio vaccine, which came along when I was a kid, that was mandated. So this is nothing new. In answer to your other question, I would consider the issue of agency. So if you're elderly in a nursing home where they had terrible COVID outbreaks, those people had no agency. They couldn't decide anything. And there are some parallels to that in very underprivileged communities. When you have a family of 6 or 7 living in a 2-room apartment, they have no agency. So if you say we need to help the people who have the least agency, that might be another way to consider it.
So that would have been another ethical approach to how we distributed vaccines. Are there any questions that have popped up in your mind during this discussion? Yeah.
I guess I just can't help but wonder about the role of misinformation. Because while I agree this is nothing new, what is new is the abundance of misinformation and the precedent by the president that was set at the beginning. So I can't help but wonder, as we think about the people who we say, haven't done anything, the role of misinformation in that.
If you look upon the list of sins, one of them was for what? For lying and leading people astray. When a person does that from the standpoint of Jewish ethics, they are again a rodaif. They are a pursuer who is endangering the life of the others in the community if the truth is that X ought to apply, i.e., people should be vaccinated. They should have 2 vaccines, or perhaps they comes 3.
We'll get to boosters in a minute. But yes, you brought up a really important point. And if we think about the rabbi's sermon last night and balancing mercy and judgment, people are believing their personal news sources. The news sources they go to are lying to them about COVID, about the vaccine, about other medications and treatments that may do absolutely nothing for them, and they are believing their news sources. And so we can fault the news sources for putting out the misinformation, but do we move to the side of compassion and mercy rather than the side of judgment in talking about people who have not done everything they can to protect themselves?
If they're endangering the community, are you going to sit around and be soft and fuzzy and compassionate, or are you going to set some guidelines? This gentleman has a response.
I had one question. In relationship, when you wind up going about communities refusing, for instance, maybe the Hasidic who are in New City, who wind up saying they don't want their women because it may cause them not to have kids in the future, or possibly in Utah where some of the Mormons may be against general vaccines. How do you deal with a large grouping where the religious part of it? And number 2 is, if you're doing mandating, shouldn't there be one agency, not state, not local government, maybe federal, to override and make sure that everything gets done accordingly rather than going back from local to local to local and nothing gets done properly?
And assuming we have a functioning federal government, which we do at the moment.
We're seeing
for
right
which
now,
I am grateful.
When we talk about the latter point that you make, at this very point, we're dealing with conflict between the CDC and the FDA and the NIH, each of which has a different pony in the race. That is to say, a standard by which they feel that vaccines should be made available and whether boosters should be made available. But let's flip back to the question of communities that say they don't want the vaccine. Some clarification. In the Jewish community, there is no one of authority who is saying that vaccines should not be taken. They should be taken. The leading Haredi rabbis of Hasidic dynasties in Israel and here, are saying to their followers, you must be vaccinated. So those who are not accepting the notion of vaccines are those who are looking at their WhatsApp, which is what Hasidim tend to look at or Haredi look at, and they're on a board that is the equivalent of a misinformation board. But in terms of the dominant Jewish community view across the board, you must be vaccinated. Mormons support vaccination. Seventh-day Adventists support vaccination. Even Jehovah's Witnesses, that many people think don't, there is a basis for vaccination. The only communities where there has been a long-standing standard, not one that's popped up because of misinformation, the Dutch Reformed Church. The Dutch Reformed Church is a predestinarian group which believes that if God ordains that you're going to die from the disease, well, so be it. So the Dutch Reform are one of the groups that can claim historically a position opposing vaccines. There are some smaller faith-healing communities. You're probably thinking of the Christian Scientists. Christian Scientists actually have a kind of an equivocal position. There are figures in the, Ken, you're shaking your head. There are figures in the...
No, I was talking to a friend whose ex-wife and family is Christian Scientist, and he had said it really depends minister by minister, that if your minister says you can do it, you can do it. If your minister says you can't, you can't, and they really have a patchwork out from everywhere as to what their official position is.
Which is why what you're seeing is you'll find mega church pastors for whatever benefit to their own ministry or their own congregation are saying, I will sign off on a letter saying that your pastor has instructed you not to be vaccinated, but you must make another commitment, whatever that might be. So it's in effect, and you've got to sign on the dotted line to get the letter from the pastor. It's not denomination-wise. Only a very small number of denominations and the Calvinist tradition, specifically the Dutch Reformed Church, are those that have a long-standing claim of not being vaccinated.
It is interesting that though halakha would say that Jewish law says that we should vaccinate, that it is many of the Haredim, both in Israel and certainly as cited in, I can tell you my last pulpit was in Muncie. I mean, the anti-vaccine going on there, the measles outbreaks, the people are walking around with mask mandates and all the kosher grocery stores there. Nobody's wearing masks, nobody's vaccinating when it's available. So it is actually unbelievable that considering Jewish law would mandate it.
So these are people who are violating their own authorities because there is some subset authority, i.e. fake news, that is laying claim, and there are some sort of offshoot Haredi rabbis that are doing that. But there's also countervailing forces in the Orthodox community, ultra-Orthodox community. You want to be together to form a minyan. There's no such thing as a virtual minyan. So what do? Well, by Jewish law, the standard is that your health takes precedence, so you do not have a formal minyan face-to-face. But in a community that places such priority on it, well, then, the heck with it. We'll get together. Likewise, studies in yeshivot. You need to be in chevrusa. You need to be in a dialogue with your chaver, your study partner. You can't do that, and you shouldn't do it through some kind of artificial means. It should be face-to-face, peh el peh. So you've got countervailing forces, but the halachic positions taken by the leading rabbis, there's no question. Everybody should be vaccinated. But there are kooks everywhere.
Now, we know someone who, in the Chabad community, who said that his entire family has had COVID, and the community, their entire community have had it. So they actually probably reached herd immunity just by infecting each other. And then we have the question of how long that immunity lasts.
And does that immunity apply in the case of new strains, i.e.
New variants, yeah.
Right, variants.
Yeah.
There's a difference between having immunity yourself and carrying it and infecting others. And there's a responsibility I think we have to not be part of the problem.
And by the way, if you're interested in looking at modeling of this pandemic and where it's going to go, the Institute for Health Metrics and Evaluation is a great site. They have models of where the pandemic is going to go. They change constantly depending upon what's going on. And one of the things that they noted is right now we're back up to 150,000 cases a day approximately. And they have a graph that says this is the number of infected, that we believe is infected people, not reported positives. So including all of those people who are infected and don't know it, who are incubating, people who have asymptomatic cases, they estimate that we have 300,000 cases, not 150,000 per day right now. And as you will see, death rates lag behind infection rate. So as you see the infection rate go up, you wait 4 to 6 weeks to see what the death rate actually is.
Just something we found out recently from our son, who went to have a test, was told he was negative. 4 weeks later, got a call from CDC looking for his contacts because, in fact, I guess they do a longer test after what they tell you instantly. He had it. He was sick for, several weeks and recovered, but he had it.
We have a situation in our family. Carol's first cousin's wife was told, no, you're fine. Whatever you're dealing with is something else. And after months and months had passed, the reality was she was...
We think she did. Other questions before? I've had plenty of topics I can bring up with this, but let's see what your questions are.
What are the ethics about trying to get people in our community to take this medicine and other communities around the world needing it and not having the opportunity?
Okay, that was the next topic, and that topic is vaccines. And if you are reading the paper and you are looking for articles about boosters, you have seen everything from people should be starting to get it, everyone should start getting a booster when they are 8 months from their second infection. And then you saw, well, maybe we should do it at 6 months. We're not sure. We think maybe we're going to move it to sooner. And it has now progressed to, wait a minute, maybe we're just going to give it to older people. We've been giving boosters to immune-compromised people. It's been all over the map.
And then the World Health Organization is saying, you're already vaccinated, those who sought out or have accepted the vaccine. Why should you be considering taking care of people for a booster when there are people throughout the world, throughout Africa, for example, who haven't been vaccinated at all? Aren't you obligated to deal with that? And I'm going to throw a nuance in here. What do you think the Jewish tradition says? I gave you the position earlier. Ken?
Didn't we say that the first obligation is to take care of myself?
Correct.
Then my family, then my community, And then you start, ever concentric circles, if you will. So if we were to say America is our community, again, from this position, not saying whether I believe it or not, then the obligation of America is to take care of America first, and with whatever is left, to give it to the world. That would seem to follow from the premise
Correct.
that we started with.
And that, in fact, is what the Jewish standard is.
But
which is
I'm going to
painful.
throw a wrench into this.
I just want to toss in, when you hear the words America first, which is perfectly appropriate in this context, and then we hear the echo. So, America first.
And here's the wrench. We're worried, we're angry at the unvaccinated people because the virus is circulating. When the virus is circulating, you get variants, and the variants can be resistant to our vaccines. Where did Delta come from? India.
Where did Mu come from?
Okay, so it doesn't matter, even if we got everybody vaccinated here, the variants come from where virus is circulating. So if the rest of the world is unvaccinated, the variants are going to come from there. And those variants we may have one that turns out to be totally resistant to our vaccine.
So it may be in our self-interest to be sending vaccines throughout the world, because otherwise we could be boosted up and down, use your metaphor. It's not going to make any difference, because you're going to go through the Greek alphabet, and then you're going to try the Phoenician and the Cyrillic and so on, because there are going to be all these different variants, because out there in the world, it continues to mutate. Hang on. Joan? Let me get this to you.
But doesn't this take us back to your initial discussion about how the vaccine is, what's the word I want, given out? Distributed to the rest of the world. The Pfizer vaccine that's sitting in CVS, whether I get a booster or not, isn't going to go to Africa.
You're right.
Am I right? I mean,
Yeah.
that's how, whether I agree with that, but that's how I see the reality. That the vaccine at Walmart and CVS and even in my doctor's office, if he has it, isn't going to go to Africa. It'll sit there. It'll either expire or not. Pfizer expires. So it goes back to the initial question, how are we going to distribute it?
So we have two levels on which to look at this. One is the individual level, and the vaccine that's sitting right here in CVS around the corner. And what we have said from the beginning is, if you are offered a vaccine, even if it's out of turn, even if you theoretically are not yet eligible for it, when you get offered a vaccine, you take it. Because there is no guarantee that that vaccine will go to someone who is more deserving. So you take the vaccine when you can, and you're right, the vaccine in CVS is not going to get shipped to Africa. So then we're off the individual level, and we're talking about a national level. Should we be pressuring our government to purchase vaccine to send to places that are not vaccinated? And some of that is happening, but is it enough?
And let me throw out some of the problems with that. I'll give you an example from days past. When there were millions and millions starving in India, and the United States quickly responded and sent megatons of wheat to India for the poor. What do you think happened? It sat on the docks because there was not the transportation structure to be able to get that grain to the people who needed it. So we're talking about a need for world infrastructure as part of the issue. It's very complicated.
And even in this country, we ran across this when we gave a talk to a synagogue in Flagstaff, where they were telling us that some of their Native American community were 40 miles down a dirt road without running water. So either getting vaccine to them or getting, how do you wash your hands when you've got no running water? And so even in this country, the problems of distribution were very real.
Maybe the time has come for the equivalent of the Peace Corps, in this case, the Health Corps, to go in even beyond whatever the World Health Organization is able to do. I toss that out as something for perhaps consideration at an action level. Marty.
Throughout this discussion, there's been an assumption of government making the determination. And I would just throw in, why need it be government? Oh, by the way, I think that's the right way myself, but why not be individual companies be doing this somehow or other, or synagogues, or any kind of organization that you could think of that may be distributing it? And that goes to the Peace Corps as well, because it was all over the place.
Other questions?
Questions, comments? Oh, hang on, Deborah?
Well, I think that one of them was answered, and it seemed to me, watching a documentary about polio, that when the first salt came out, you saw people around public schools, 3, 4, 5 people deep, and the answer, and I was thinking, why then? Polio is certainly horrible, but so was COVID, and I think Lady Bear had the answer, the information we're getting. I don't think there were so many naysayers for the polio. And
Right.
I'm just wondering though, why now we're so, a gift has been given that we have this vaccine, and why so many people have.
One thing that is able to be offered is that in those days you had people like Walter Cronkite and others who reported the news and reported the true information, as opposed to information becoming commercial, i.e. you wanted to sell your particular brand, i.e. the medium is the message. And so you have Sinclair as a countervailing force to mainstream media such as NBC, ABC, CBS. The proliferation of information has allowed for the proliferation of misinformation.
And if you believe you have a political advantage in keeping people angry, then anything that you can get them to rail against keeps them on your side.
Whether it be in business or in politics.
So, I think that is part of it. Yes, this is a wonderful thing. We're going to tell people it's a bad thing and make them angry because people are pushing it on them. So I think that's political. And I'm getting waved at with gestures. I am not
That was simply a hi, Mom.
Was that a hi, Mom, or was that a...
Yeah, are there any Parthian shots? Any finishing comments that anybody has aside from to us?
You started out with, the 2 people, I had the shot, I didn't have the shot, and obviously this is happening as we speak somewhere. What are people doing in the field?
People are treating patients as they come and basing their treatment on the medical situation. Now, it is possible, it looks like the person who is vaccinated is more likely to survive. They are less likely to die. So if you do have scarce resources, and there probably has not, well, no, I shouldn't say that, but if If the vaccinated person is more likely to survive and you only have enough treatment for one person, based on the principles of triage, you would give that resource to the person more likely to survive. I was going to say that those situations haven't actually happened, but in Starr County, Texas, in June or July of 2020, the local hospital, which was a small hospital with a limited number of beds and a little number of ICU beds, and the county made the decision that if a person came to the ER with COVID who was looked to be too frail or too sick to survive, they were going to send them home. Because if they admitted them to the hospital, they would have to ship them thousands of miles away and they would die alone, somewhere thousands of miles away. And so in Starr County, Texas, in the United States of America, they decided that they would send people home if they came in and didn't look like they might survive. So it did happen here.
But the decision was based on the fact that they decided that person would die. That decision was based on the fact that they decided that person would die. So the issue became then was where were they going to die?
They said if they were too sick or too frail, that they were unlikely to survive. So would some of those people have survived? Did they actually end up sending anybody home? I don't know, but that was the decision. They were in crisis. They were in system collapse.
Okay, I'm going to do a pan of the room. If you have any closing remarks that you would like to make, please raise your hand. Because by the time I get to the other end of the room, I'm dropping the mic.
So while he's doing that, if you don't have an advance directive, if your children don't have advance directives, if their children don't have advance directives.
There's no way you can get away from commercials, folks. I'm sorry.
Thank you so much for nudging us. No, just kidding. Thank you so much. Thank you. Thank you both for your time, your thoughtfulness, and we will be regathering here at 5 p.m. for you. Sorry, we will be regathering here at 5 p.m. for Yizkor. Thank you all for being with us. You're free to hang around the synagogue, to schmooze. Yeah, we'll be here. We're just going to be hanging out.